Next. So acknowledging today that we're on the land hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, Tsleil-Waututh Nations and Métis Charter Community of the Lower Mainland region, and recognizing that wherever you are in this province or this country, a commitment to truth and reconciliation, understanding the land, the people on it, and learning to live and take so that we have this land for generations to come is very important. Next slide. Province-wide round is a collaboration between UBC Division of Nephrology and BC Renal, along with our industry partners and all of you in the different health authorities. We aim to bring a robust, meaningful, and clinically relevant set of educational activities to you through these rounds, and today will be absolutely no exception, I'm sure. Next slide. So today we're going to hear about renal obstetrics care in this province. We have three outstanding speakers. Dr. Monica Beaulieu is the division head of nephrology at St. Paul's Hospital and the medical lead for the Kidney Care Clinic and the inaugural medical director of the Nephrology Obstetrics Clinic. She has a special interest in training nephrologists and those in OBIM and MFM in the care of people who have kidney disease, who are considering pregnancy and throughout their journey. Dr. Elizabeth Hendren is a clinician and researcher with the Division of Nephrology at UBC, also based at St. Paul's Hospital, and is a transplant nephrologist and with an interest in renal obstetrics, especially in pregnancy and renal transplant patients and recurrent glomerular disease after transplantation. And Dr. Amanda Cunningham is also a transplant nephrologist and has a clinical fellowship both in glomerular diseases and kidney diseases in pregnancy through University of Toronto, and then did a Master's of Health Sciences and a transplant fellowship at UBC, and is practicing at Vancouver General Hospital. And her interests complement those of the other two physician presenters, including women's health, patient education, and improving care for people with recurrent disease. And we have a guest appearance as well of Mrs. Kate Chong, who is a patient partner, as well as has a role at the Kidney Foundation of Canada, Yukon, and BC branch. So we have an amazing cast for you today, and I'm going to hand it over to our presenters. So over to you guys.
Sounds good. Thanks, Adira, for the introductions. I will start, and it's thank you for the invitation to speak today. We're very thankful for the opportunity to share some information about pregnancy planning for patients with kidney disease. I'd just like to start briefly by highlighting and having us remember that reproductive health is a recognized human right by the World Health Organization. And that right is not just for healthy patients. That right is for people with chronic diseases, including kidney disease. And in the past, women with kidney disease were often advised against pregnancy. This might still occur with women having been not really given the clear information of the risks of pregnancy, and importantly, the possibilities of success. Granted, there's a lot we don't know, but there's also a lot we do know. We hope to share some of that with you today. And since we continue to learn so much from our patients, that we've been able to serve how they navigate their kidney disease with their desire to have a family, how they process the risks and rewards of deciding whether to try to have children, how what we say matters when we outline those risks and how we say it, and how it lands with patients and impacts their decision making is quite outstanding. And so the patient perspective is the most important perspective. And so I'm extremely grateful and thankful to introduce Kate Chong on a very important day for her, who many of you know from the Kidney Foundation. Kate's offered to spend a bit of time with us sharing her personal perspective of her journey as a kidney patient who's navigated the journey of pregnancy. And so Kate, can I hand it over to you?
Yeah, thank you so much. I greatly appreciate the opportunity to share. And as many of you might know, I'm the Director of Programs for the Kidney Foundation BC Yukon branch. But today I come with you on my personal journey of diagnosis all the way through to wanting that dream of having a family. So pictures tell a lot about a story, and so I've chosen a few here. And kidney disease can affect anybody, no matter the age. And for myself, the middle photo there, that's actually me in an ambulance being transferred from my small community hospital to one of the bigger city centers, completely probably oblivious that what lied ahead of me for my kidney disease. All I knew is that my kidneys weren't working properly, and that I was not, and my heart was also not doing super great because I had really high blood pressure. Little did I know I was on the brink of needing dialysis at that time. So it was a big, huge piece, a big life-altering moment. And so, after I kind of things settled down and I was able to stabilize, thankfully, and be able to, kind of actually regain some kidney function, which was amazing. Being in my mid 20s at the time, naturally with my care team at the time through my kidney care clinic, I said, what are the options, for having, a family in the future? I wasn't ready at that point, but I wanted to discuss that with my team to let them know that that was a goal that I personally had along my journey. So fast forward a few years, I meet the person that I want to spend the rest of my life with. Brian is, we've been married coming up 8 years, I guess, now this year. And he knew about my kidney disease coming into it. He also really wanted a family. And so it was a really important piece for us. And along the way, of course, wanted to get involved in the kidney community very heavily to, give back. So volunteering with the Kidney Foundation here in BC and Yukon, but also doing things like the Kidney March out of Calgary and walking 100 kilometers and raising money to continue research and give back to the community and let people know that, we're here all together as a kidney community. Brian and I got married, and the hope was to start a family. We just after finding out that I was needing, or after we got married, we tried to make a med change, and that didn't unfortunately go very well. So my kidney function started to decline. So it became apparent that I would need a kidney transplant. So it was a pretty, somber moment at the beginning of 2017 to be told that, hey, I'm sorry, you are unable to have a family right now, and you need to focus on getting a transplant. So that was a process, and who knew the man I had just married a few months before would be actually a kidney match for me as well. And so we found out, and again, along the process with my transplant workup team, I made it very clear that a family would be my future plan if everything was to go well. And they were 100% behind me. And, as soon as so we had our surgery in September of 2017. And I would say exactly that 1 year later, it was kind of that 1 year follow-up meeting. I said, great, so we're at 1 year. Everything's going great. I'd love to try to find and have our family sort of thing. And so that's when I got referred to actually Monica, which was wonderful. And helped me, okay, let's start the process, make the med changes. That went well the second time around, thankfully. And the process of, okay, now it's time to just try to have a family, which, just like everybody else, you don't know when that's going to happen. And that took a while, And I actually said, okay, age-wise, now I'm getting closer to mid-30s, so we got referred to IVF. Little did we know, and actually, my obstetrician, Dr. Joa, that I actually still have a voicemail on my phone today of her calling me saying, hey, Kate, we did our test level and it looks like things were, a certain level was really high. She's like, I'm speculating you might actually be pregnant. So little did I know that IVF journey was not needed in ours. And very fortunately, I became pregnant with our first daughter and our first child. And this is a really cool photo. And I know Monica and Dr. Joa and many others love this one on the far left-hand side on my screen, at least. If you can see it, it's got Addie's little head there and her little arm beside Brian's kidney. And it's a really special photo that we have framed in our house because it just shows the beautiful gift that Brian gave me, allowed us to have our beautiful child. Now, of course, the journey itself never comes without ups and downs, as any pregnancy does in some ways. But overarching, I was kind of boring. I was, which is, I guess, a good thing when it comes to the journey. Though, we knew, especially as we got closer to delivering, that the chances of an early pregnancy was a possibility. And she definitely decided that that was the case. And so she did come a whole month early. Now I was able to deliver her myself with some help of doing, but was able to deliver her and have a natural birth with her, which was, it's unique experience in itself. Post, my health was very, very stable actually. There was those initial things, a lot of blood loss and that sort of thing. And so I was worried about, I was close to needing a blood transfusion. Thankfully, that didn't need to happen. And so I was very thankful for that because being a transplant recipient, having any type of thing, including pregnancies and things like blood transfers, that those high sensitivity might come into play. So thankfully, Addie was a happy, healthy little girl and joined us actually exactly 4 years ago today. So we will be celebrating her 4th birthday today. Following probably about 3 months later, I had a follow-up appointment and I said, I know she's just little and everything's going really, really well, but I really want to have another, child if this is in the cards, sort of thing. And so, we weren't in a huge rush, but seeming the first time took a little while. We started a little bit earlier than I expected, and it didn't take as long the second time. And so we were so fortunate to become pregnant with our second child, Ashton. And again, the pregnancy itself was quite, there was those typical things to monitor, my blood pressure, medication levels, changing those, working with the team between both my transplant team and my specialty team and my obstetrician. And it was a comprehensive team that helped me through these pregnancies and having those extra checks and C-sections, or not C-sections, sorry, ultrasounds. And Ashton was a big boy. He was breech and he had a large head. So definitely as we got closer, the idea of delivering him was slightly terrifying, and he was breech, and I just didn't want to take the risk. And so working with my specialized team, to decide what we were going to do. And it was decided based on his size as well as being breech that a C-section was the best option. And so at 37 weeks exactly, I was able to go through the process of having a C-section with Ashton. Now, I forgot to note during my pregnancy with Ashton, though it was pretty boring again, I did have COVID in that time. So that was an added piece. My daughter had caught it and gave it to me. And I did do the intravenous. I apologize, I don't remember the medicine off the top of my head, but I definitely had a lot of questions and concerns. And my team talked me through, that there wasn't a lot of data saying that there was risks to a pregnancy, that sort of thing. And thankfully, everything was fine in that sense. The recovery for Ashton, there was definitely a few things within the hospital setting that, I continue to encourage the communication amongst, knowing that the maternity clinic knows that, it's a transplant patient, both for myself as well as Ashton ended up in NICU for 6 days. And just knowing that sometimes, being a transplant recipient, things like my MMR levels might be low, but I can't have that vaccination anymore. And thankfully I knew that, but I was asked about getting that vaccination. I said, I can't. So things like that, just to communicate, to continue to bring it forward. So to bring it through, here we are 4 years later, and, that we're being able to live our dream with all the sheer craziness of having a young family of Ashton will be 2 here in July next month, and then Addie turning 4 today. So I'm very thankful for the opportunity, one, to have a supportive team all the way through my journey from starting almost 13 years ago until today, where, having that goal, and I know that not everyone is the same, but, having those conversations, referring them to that, the extra wonderful, who we'll hear from now, professionals that are doing this to help patients look at the opportunities, the risks, and that sort of thing, so that hopefully they can make a decision within their life if they want to do that forward. So I appreciate the opportunity to share my story on a personal side, and a success that we've been able to have 2 healthy children following a kidney transplant. So thank you for the opportunity.
Thank you so much, Kate. You know, when we were thinking about planning this day, we knew that we wanted to have a patient perspective at the very beginning, because this field of nephrology is all about doing this for the patients, right? Allowing people to have these meaningful and important life events, grow their families. And so this is why Monica, Amanda, and I just love this area of focus that we do within our days. It's the highlight of our weeks when we get to do our clinics. And we hope to share a little bit of the wisdom that we've learned over the past few years with you all today, and to equip you with skills and empower you to know when you can manage things on your own and when to refer to us in Vancouver, to let you know about extra resources that we have, and to really bring everybody into the fold in terms of what we're doing in BC right now. So is there a role for nephrologists in preconception counseling? I think if you were to ask the nephrology community, 15, 25 years ago, the answer to this would be no, because there's no role for pregnancy amongst kidney patients at all. But now we do know that there are very specific things that nephrology can provide, and it's actually essential for kidney patients that their nephrologist be involved in preconception counseling. So a nephrologist have specific information about the prognosis and trajectory of a patient's kidney disease that other providers that may have more of an interest in obstetrics are not going to be able to answer. As well, nephrologists have access to pre-pregnancy diagnostics like a kidney biopsy, which may help clarify disease activity and also further help delineate pregnancy risk. And then finally, patients want to talk about pregnancy with their nephrologist. And so studies time and time again have shown that one thing is very consistent amongst patients is that they desire these conversations and they want to be having them with their nephrologist. So this is an important thing. And we know that right now, this is not happening on a frequent basis. And so this was a survey study I helped coordinate during residency, looking at over 150 nephrology providers in America and Canada, asking about the frequency of counseling for nephrology providers. And so only 22% of Canadian providers were offering contraception counseling, 16% offering preconception counseling, and 13% offering pregnancy counseling more than once per month. So this is something that a majority of nephrologists told us that they were doing on an infrequent basis. Now, we can imagine most nephrologists would be seeing far more than one person per month of reproductive age. And limits were, we went a little bit into what some of the limitations were and why people were not sharing, having these discussions. And there was a lot of comments on lack of training and lack of resources. And so we'll be chatting a little bit more about both of those today. So the first thing to know about counseling patients for pregnancy is that pregnancy is possible in all stages of CKD. And when you're opening up the discussion, the way that we approach this as providers can have a huge impact on the patient's takeaway. So even how we frame this discussion, whether we think about using more of a success-based counseling technique where we focus on sort of the best case scenario and informing of the possibilities, is probably a bit more advisable of a strategy when opening up the discussion, as opposed to a warning-based counseling system where we're thinking exclusively about the risks and making it impossible to sort of envision the best case scenario. Now, obviously, somebody who is, in a very active part of their disease may not do well with a success-based counseling approach. And so obviously this is very individualized, but many patients with kidney disease can have this, do well with this sort of success-based approach. And one possible strategy is to sort of think about this as a sort of cyclical thing. So you're opening up the conversation, by having the nephrologist initiate the discussion, not waiting for your patients to talk to you about their desires for pregnancy. having the discussion to the extent that you are able based on the patient's current clinical status. And that includes communicating the risk and discussing patient preferences, discussing optimal timing of conception, and then looking for opportunities to optimize medications. And then opening this up with a reassessment, recognizing that people's family values and desires may change over time, and looking at discussing fertility referrals if patients have not conceived within 6 months to a year and are still desiring pregnancy.
So we also wanted to take the opportunity to structure this a little bit around different questions that patients have in clinic for us, because often this is something that women have been considering for a long time. It's a complex enough decision without the kidney disease piece. And so adding that on top, we do hear a lot about how will my kidney disease affect the pregnancy in terms of concerns about complications. Will the baby be healthy? Will they be expected to be delivered early? What to do with medication management? And then the converse, like how will the pregnancy affect my kidney disease in terms of trajectory? Will things change quicker? Will the options available to me be the same as they would have been without the pregnancy component? For patients with a transplant, implications around that in terms of sensitization or timeline through their course of kidney disease care. And then somewhat directed by us as well is a conversation about what's the best window of opportunity, because often this is like an important part of what women want along their life trajectory. And so helping them identify different opportunities that might kind of jive well with where they're at with their kidney disease is part of our role. How to prepare them best, any diagnostics or different treatments that need to be done in anticipation of that, and how to best reduce the risk of common complications like preeclampsia. So how will my kidney disease affect the pregnancy? In answer to this question, we know that miscarriages and infertility are not necessarily more frequent in kidney patients, but there's not a lot of data available about this, and something that we're hoping to eventually investigate in our own population here in BC. Although we do have a lot of patients, and hearing Kate's story, that do deliver early, full-term pregnancy is also possible in all of our patients, including those that are on dialysis and have a kidney transplant. But you know, we make decisions together with the obstetrical team to decide whether or not early delivery is necessary. And then one of the main things that we spend time counseling on is the spectrum of gestational hypertension and preeclampsia, and things that we can do to decrease that risk, which would include aspirin prophylaxis. So one reason why we like to see patients in preconception counseling or earlier in their pregnancy journey, so that we can kind of capture them prior to that time. Questions about sort of fetal malformations, other issues with baby. Because of the prematurity, we do see some developmental issues and NICU care, but not higher than the general population. And there's not a higher incidence of other fetal malformations, unless there's been a genetic condition that's relevant in the case. Medication changes, the common ones that we chat about with patients. For most people, we'll stop the ACE or ARB. Definitely in all patients during their pregnancy, but in most people prior to conception. And one of the sort of paradigms we tend to use is if there's an underlying glomerular disease or something that we want to investigate residual proteinuria prior to pregnancy, we like to sort of know what that's sitting at. And so we may pursue a biopsy, or we might look at optimizing immunosuppression going in, as opposed to patients that have something like diabetic nephropathy. It might be in our best interest to continue RAS blockade as long as possible, even extending it to the positive pregnancy test, just to try to minimize the potential rise in proteinuria throughout the duration of the pregnancy. And then other common medications for our patients, statins, SGLT2 inhibitors. For the transplant patients who are on PGP prophylaxis, we stop their Septra. And then again, relevant for transplant and GN, we do switch the mycophenolate to azathioprine at least 6 weeks prior to conception, although often it can require a bit of a longer course if they're running into issues with cytopenias or other problems and require a bit of finessing of the dose. And then how will the pregnancy affect my kidney disease?
So you would think that we'd know this answer by now, but let's take a step back and go through a bit of normal renal physiology just to remind you in a healthy kidney. So I don't think I have a pointer, but structurally, it's important to know that the ureters and the renal pelvis actually dilate due to the hormonal effects of progesterone, due to external compression, and you get hydronephrosis sometimes bilaterally, but more on the right than the left because of the way the vessels and the ureter are on the right. And interestingly, there's evidence that at the glomerular basement membrane level, the pore size actually does increase, which probably contributes to the physiologic proteinuria in addition to the hyperfiltration. Going up to renal hemodynamics, it's amazing that you have 50 to 85% increased renal blood flow, 50% increase in your GFR. The kidneys actually get 1 centimeter to 1.5 centimeters bigger from that blood flow. And there is quite a bit of evidence that physiologic hyperfiltration, that ability of your creatinine to go down in pregnancy, is a good prognostic factor for the pregnancy. In terms of systemic changes, so we know that our blood volume increases, our SVR, systemic vascular resistance decreases, our cardiac output increases. And in the kidney, even though RAS is activated, the sensitivity to the renin system goes down, there's more water retention, and your plasma osmolality also goes down, due in part to reduced threshold for vasopressin release, and your serum sodium will be lower. Endocrine functions change. Erythropoietin activity goes up if it can, and RAS activity goes up, although you're less sensitive to it. And at the level of the tubular, you do get more glucose spilling. So if you see a pregnant patient with glucose in the urine, it doesn't mean they have gestational diabetes. It's normal. They have increased calcium excretion, and they reabsorb uric acid less. So you should see in your labs lower creatinine, lower uric acid, a slightly lower sodium, about 4 or 5 millimoles per liter lower than their pre-pregnancy number, a slight metabolic acidosis, which is not shown here, but because you have a respiratory alkalosis due to increased minute ventilation, you'll have a compensatory metabolic acidosis, and your bicarb will be down about 3 or 4 as well, as normal values in pregnancy. So when we see everything the kidney has to do, the next question is that hard on the kidney if someone already has kidney disease? And answering this question, how will a pregnancy affect my kidney function, is both vitally important and historically difficult, especially due to the heterogeneity of kidney disease and progression. You know, some data had suggested, and then others had refuted, an association between CKD stage and loss of maternal renal function. The studies were small. They had very few people in later stages of CKD, and they had very short follow-ups, and they didn't really examine the trajectory pre and post pregnancy. So this recent retrospective review is important. It was published by Wild out of the UK in 2021, and they only included CKD 3 to 5. And they had 178 pregnancies, and about 47% were stage 3A, 38% 3B, and about 15% stage 4 and 5. So still relatively small numbers. Important to note, they had a 98% live birth rate. So very successful outcomes. In general, they showed that the risk is low in early stage disease and increases with advanced disease. But what I really want to be able to tell my patients is, how much does having a pregnancy increase your risk? What's the change, or is there a change to their trajectory? How much kidney function extra am I going to lose? So this figure here has eGFR on the y-axis, and then the pre-pregnancy GFR slope The pregnancy is between the two red lines, and then the post-pregnancy GFR slope. And, you know, to your eye, you can see, and you're right, that the slope, the trajectory of GFR decline wasn't different pre-pregnancy and post-pregnancy. But what you can see is there was a little bit of a stepwise decline. The GFR that they started after pregnancy was lower than the one right before pregnancy. And so when they modeled it, they were able to tell us that in this cohort of patients, in patients with stage 3A disease, a pregnancy was equal to about 1.7 kidney years of progression. Stage 3B disease was about 2.1 years progression, and stage 4 to 5, 4.9 years of progression. So it does help us, and I find this study quite powerful to be able to talk to patients when they look back and said who was more likely to progress. Very interesting that almost all the patients that had that step had chronic hypertension, and almost all those patients that had that step didn't have a decrease in their creatinine by 10%. So when how do I use this? So I often share these results with patients, trying to let them know where I think they are based on their proteinuria, their hypertension. But I do, you know, paint the best and the worst case scenario. And for those women who have a risk of renal replacement therapy within 5 years without a pregnancy, then I do add the counseling in that pregnancy might precipitate the need for renal replacement therapy, knowing that there was this step of 4.9 years in the stage 4 to 5, just to explain what that is, what the rigors are, what they would have to do, and is something that they would be willing to risk. Next slide. So we have decades of experience in transplant patients with even more data, but there is actually still equipoise with respect to the effect of a pregnancy on the allograft outcome. There's still some conflicting results. Some show an increase of graft loss, others show no effect. There were a couple recent, quite fulsome studies. One was a meta-analysis by a Dutch group. They had 38 contemporary studies. It was quite recent. And they did notice that the creatinine was a bit higher at 2 years post-pregnancy, so up by 16, but then not increase at later time points. And reassuringly, there wasn't any increase in graft failure at 10 years in that study. And then in another study from Kata and the Mayo Clinic, this is where this graph is from, they looked at transplant patients who had a pregnancy versus transplant patients who did not have a pregnancy. And they reported that pregnancy didn't affect the risk of graft failure, death-censored graft failure, or a 50% reduction in the GFR at 8 years of follow-up. But they also looked at the GFR trajectory, and the graph there shows on the y-axis of the eGFR, on the x, the years pre and post-pregnancy. And they did see that the creatinine trends post-pregnancy with the red line were a bit lower. So the rate of decline, the slope in this patient population was 1.7 mils per minute per year before the pregnancy and about 2.4 after. So there was a bit of a decrease. And it's not surprising to anyone that practices nephrology that your pre-pregnancy proteinuria, hypertension, and creatinine are at risk factor for graft loss. So how do I use this information? If a transplant patient comes to me with good kidney function, no hypertension and no proteinuria, I tell them that their function is going to be, like good after pregnancy. And if they have proteinuria, hypertension, their creatinine's already elevated, we talk about the increased risk that might come with it. Next slide.
Okay, so when should I start trying to get pregnant? Putting this all together. So ideally, our favorite time to talk about all of these things that we've mentioned is pre-conception. Lead time is great for us because it gives us an opportunity to try and optimize things for patients where they may not necessarily be coming in with those good prognostic factors. Kidney function being a harder one to change, but perhaps proteinuria and hypertension. Things that might influence the plan here include timing factors. So that might be patient preference for family size, you know, whether or not they already have any children, what they know about their fertility status, whether they might require assessment or treatment of that nature, how they're doing clinically, how close they might be to dialysis, as we just saw, whether they're early CKD versus late stages, and counseling about dialysis is required, or whether they've already been transplanted. And if they haven't been transplanted, implications for future transplant, sensitization, etc. And then a big one also being age, where we're starting this discussion. So if patients are in their 20s and we perhaps have more lead time to try and perfect and optimize things versus if they're in their 30s and want multiple children, you know, it may kind of change the way that we're counseling and planning here. And then we do cover the things that we just spoke about in terms of maternal risks, primarily hypertension, preeclampsia, and other issues with mom, as well as impact to their kidney function trajectory or transplant function. And then fetal risks, including, you know, having small for gestational age infant, having baby early, requiring NICU care, etc. And making sure that medication factors have been addressed, as we spoke about, stopping things, switching things, and just generally trying to optimize blood pressure as well going into the pregnancy. We also wanted to touch on, just to give an example of a disease-specific counseling that we might do with patients. We do see a lot of women with lupus and chronic kidney disease, so things that we would aim for would be good period of disease quiescence, at least 6 months prior to pregnancy. We tend to see that there's often fairly good degree of quiescence during the pregnancy, but that flares can occur postpartum. So we are on the watch out for that, and we do follow patients up with a postpartum visit just to kind of see how they're doing, and then they're generally transitioned back to whatever their primary care is. And then we continue Plaquenil. There's good evidence to suggest that this reduces flare risk and can also have some impact on preeclampsia risk. And then in general, biopsy is something that we aim to avoid. It does have increased bleeding risk in pregnancy, and there can be challenges with timing. So our goal would be, particularly for patients with GN, lupus, or some complications of transplant, that we would discern whether there's a need for biopsy going into pregnancy, deal with that and optimize medications or immunosuppression going in, as opposed to having to deal with that in pregnancy. But it is something that we occasionally have to contend with if it will change the management.
So it's really hard to give actual numbers for patients and when it's actually time to give them the green light. So one way to do it is to do more a stop sign approach. Patients that are optimized and can attempt pregnancy, people that we need to have a bit of caution and think a little bit, and people that we might want to wait on. It doesn't mean we will wait forever, but we might wait until we are sure that we've addressed all the risk factors. So in people that it's, you know, go time, blood pressure targets are less than 130, normal eGFR, if you can attain no obesity. These are usually people that come, and an ACR or a urine protein less than 500 milligrams a day. So these are people that have either interstitial disease, previous renal scars from something, and probably donors. In people that we caution and say, is there something we can optimize before we give the green light? Can we wait a bit longer? Blood pressure, but controlled on medications, proteinuria up to 1 gram a day, blood pressure that is not at target, and increased BMI. Obesity is a very difficult one, an evolving one with all of the literature and the meds coming out for obesity. Waiting for a certain BMI is not what we do, but just to see if there's anything we can optimize in that way. And in terms of waiting, there's sometimes we can wait, like if there's been a GN or a lupus flare within 6 months, if there's proteinuria that can be treated, if you have proteinuria that can't be treated, and that's the number you're going to be at, we don't wait forever. If you can and have the luxury of a year within acute kidney injury, or if you have an eGFR less than 60, those are patients that we have to wait, see, make sure we can optimize.
And then for transplant patients, we want to wait in patients who have acute rejection, less than a year post-transplant, uncontrolled blood pressure, and fluctuating graft function, and proteinuria. So very similar to CKD. There's some data that shows that the optimal transplant outcomes are in people who have been at least 3 years post-transplant, but we also know that many people cannot wait. And so as long as you've waited at least 1 year, we generally give the green light. The exception would be if someone's in their early 20s and has time to wait. Again, we see very similar, the control of the blood pressure, but on medications, and our GFR cutoffs are a little bit lower than the CKD population. And so, these are general, it's generally the same risk factors for progression of disease in both transplant and CKD patients. And it's important that people, can still get pregnant even with high risk factors. It's just, whether people, it's just takes the counseling, and for some people it may make the most sense to pursue a pregnancy even if they are in a higher risk group, with the exception of things like within 1 year post-transplant we really don't advise, so there are some things that we're quite firm on versus others that, like Monica mentioned, sort of the proteinuria, if we're not able to control it, or if the GFR is below 60 and that's the best that we can do, we don't necessarily have people wait indefinitely. And so one thing that we can do in our clinic is I advise people on the optimal time of pregnancy during their transplant. And so some people with advanced CKD, this can be a very challenging discussion. And so we love to see these complex cases referred to us, or we can offer virtual counseling and help provide people with perspective about fertility preservation, undergoing transplant first versus choosing to pursue a higher risk pregnancy on a transplant, on dialysis. So we will consider a variety of different things in this discussion, as Amanda mentioned previous. Just to remind patients that when they do pursue pregnancy on dialysis, that this is a more intensive schedule, so ideal for a home dialysis patient. And then considering things like the risk of sensitization, as Kate mentioned, with a pregnancy before transplant.
I'm happy to see some. Go ahead.
Yeah, go ahead, Evan. No, go ahead.
We know that there's a lot of expertise around the province, and many of you are on the call, and so I know you guys do this most weeks. For local nephrologist management, the straightforward cases, the stable transplant, the early CKD, and for the providers that have experience with pregnancy, that's generally what's recommended. I would say for those patients, the one important thing is the aspirin prophylaxis. I think it's important for all of us to be knowledgeable about when to start, usually starting, at 12 weeks, if you have a dating ultrasound planned after the dating ultrasound, and then continue to 36 weeks, because sometimes the fact the patient has kidney disease, especially early stages, gets lost in the shuffle of a new pregnancy, especially with our GP crisis. We have the option of a shared care model with St. Paul's Renal Obstetrics, both transplant and general nephrology, and have the opportunity to provide virtual consultations, follow-ups, and in-person visits. Urgent referrals can be seen within 2 weeks. Honestly, if you have a question, you're worried, just text one of us and we'll get back to you right away. Next slide. So we're currently running about twice a month with both transplant and general nephrology. And for those pregnancies that are delivered at St. Paul's Hospital, the complex medical obstetric patients, we do have a once a month full complex care visit where we have virtually the MFM, OBIM, the obstetrician that will be delivering, any learners, and a clinical nurse specialist just helping us out with care plan. We're developing shared care with Fraser, the very fastest growing amount of patients. They're developing all these resources as well, and also offer one-off preconception and fertility counseling. So the people that seem to be referred and have the most benefit, really anyone you're worried about or the patient is overly concerned and would like it In general nephrology, those with GN, progressing CKD. If you're wondering, should I biopsy the patient or not? A common question. Post-transplant patients contemplating pregnancy or who are pregnant, pre-transplant who have questions around timing, and others including previous living donors, previous AKI. We've been blessed with many fellows from the nephrology fellows, the transplant fellows, OBIM and maternal fetal medicine that are learning from us to help create this community. Next slide. We also do a 6-month postpartum visit where we talk about post-pregnancy counseling. You know, how did it go? Let's make sure the medications are restarted. Let's make sure you get something started in breastfeeding if you need it, and contraception. In terms of how to refer for those that are have the luxury or the challenge of using Cerner, there is a refer to outpatient renal obstetrics in Cerner. And next slide, there's also, we've created a referral form, and I didn't ask my son for help. I did this QR code all by myself. So for those that know, that's amazing. So hopefully it links to actually this referral that you could formulate for your EMR. Next slide.
Yeah, so we just wanted to conclude. We'll give you a few minutes for questions, but to remind you that pregnancy can be accomplished at any stage of kidney disease. If you start the discussion, we can help you finish it if it becomes more complex. And we have the capacity right now for more patients and trainees. So feel free to refer us, to call us. You know, we are ready and able to take on more. So part of the hope today too is that you may think through some of your more complex patients that maybe want a second opinion, or maybe, you know, have questions that you don't have the time to go through in a short follow-up visit. And we're very happy to take, you know, those more complex discussions. And I just wanted to throw this resource in here because a lot of the information from today is supported by this wonderful Clinical Kidney Journal article that just came out, which is it's a beautiful summary of the risks and the different things to focus on with the preconception discussion. And it specifically highlights a lot of different diseases and how they can be optimized. And so this is a really, really fantastic resource for preconception counseling, and something that's worthwhile reviewing before discussing with a patient. And so with that, we'd love to open up the floor to any questions and discussions that people have.
Great, thank you for that. Terrific. Maybe we stop sharing so people can see, but thank you for that excellent overview, but also for the dedication that the three of you put into sort of standardizing and organizing such an amazing resource and working with our colleagues around the province. So that's really terrific. Questions? Someone has their hand up, so we could unmute you, I think. Susan Cooper.
Hello. Hi, it's Susan Cooper, one of the nephrologists within Fraser. And I just wanted to give a huge shout out to Elizabeth, Monica, and Amanda, helping me with a lot of my challenging patients in Fraser. And I've been doing a lot of this work for the last 20 years, but we're trying to formalize it in Fraser, and similar to what you're doing in Vancouver, and doing more of a shared care model. So I really do appreciate your expertise. Just a couple points I wanted to make, and I'm seeing this more and more within Fraser as we have more people move out our way, and it's generally a younger population. I'm sometimes seeing young women who've been followed by other nephrologists, and it amazes me, even in my young patients who have already had 3 children and have stage 4 to 5 CKD, contraception hasn't been discussed with them. So just because they've already had children, it somehow gets missed that they still have the ability, even if their GFR is down to 15, to get pregnant. So that's one thing I'm noticing, that these discussions aren't ongoing. And secondly, what I've noticed is I've had a young woman who had Alports, was under the notion that she wasn't able to have a child, and if she did, her child would have a high risk of getting Alports. So I think that's the other thing is, you know, with some of these genetic conditions, knowing that genetics referrals are possible as well. So, you know, that's what I'm noticing. And my question to the group is, because not all nephrologists are going to feel comfortable, number one, talking about birth control or talking about preconception planning. So how do we get the message out there? I mean, really, any woman under the age of 45 and maybe even under the age of 50 we should at least, make them aware that they can, if their nephrologist does not feel comfortable having this discussion, that maybe to get a referral to one of those who are pregnancy trained. Because I think that's the biggest thing that I want to work on within Fraser is not everyone's going to feel comfortable having that discussion, but at least letting patients know that resources are available so that they do have the opportunity to have their questions asked.
Yeah, no, thanks, Susan. And I think the birth control one, it's not that hard, right? So I think that's somewhere where education can be quite helpful provincially. So we really hope to work with you and standardize and every patient we have on dialysis, transplant, and in CKD should have had this discussion in their childbearing years. And it's actually not an overwhelming number of patients. So definitely hoping to work on that to make us all comfortable.
I guess to the point also, like developing provincial standardized resources that are posted on the website, so that will also improve everyone's literacy around this, because I think, not everyone's comfortable about talking about different aspects of care, and I think it's great to hone that and take your guidance and your expertise. Sumit and Sean both have their hands up, so Sumit, on to you, and then Sean.
Thanks. I've had quite a few people go through pregnancy with me, and primarily GN patients, a few PCKD patients, for example. I have one particular patient, who has lupus and had some sclerosing lupus, had quite significant persistent proteinuria. And you talked about optimizing proteinuria. Well, we got her on the RAS blockade. She's on the SGLT2 inhibitor, but then, with each subsequent pregnancy, she spends almost a year off those meds, and then proteinuria increases. She has consistently had increasing proteinuria during her pregnancy. And so, there's, in terms of that progression map that you showed, Monica, how much, she has CKD stage 3 still, but she has untreated severe proteinuria for like 5 years, right? So even though GFR might be relatively preserved in that setting, there's probably even higher risk of progression. What's your experience with that?
Absolutely. And your time off treatment, number one, minimizing it's very important. So I've seen people, I'm not going to put them back on their ACE and ARB because they're considering another pregnancy or they're breastfeeding. So there are safe ACE and ARB in breastfeeding. And so, but that time off treatment does confer a risk, and those studies aren't big enough to show what that risk is. So I think just informing the patient that the time off treatment confers a risk. And patients will, as you probably know, patients will make the decision they make, but absolutely, that time off treatment does confer a risk of progression when they're not being treated for their disease.
And I think what a lot of patients, the perspective they have too is like, well, family is so important to me. And I know with this amount of proteinuria, you're telling me I will need a transplant at some point in my life. And so whether I need a transplant 4 years from now or 8 years from now, for me, that is a worthwhile risk that I am willing to take, as opposed to just missing my childbearing years altogether. And so that's where that sort of like, that pregnancy risk, where we're thinking about the number of years of pregnancy life lost for many people, a transplant, in 2 years versus in 4 years, that 2-year difference, say with a CKD stage 3, is actually, it's not the difference between never needing renal replacement therapy and transplant or not. It's sort of just pushes things forward a little bit. So that helps patients put it in perspective too.
Yeah, I think that's a huge, important perspective, right? You will need our renal replacement therapy. It's a matter of when. And I think that's a very important, nuanced, and personalized approach that I think perhaps has been missed in much of the literature and some of the, stuff that people have talked about. So yeah, thanks for highlighting that. Really
just to follow up on that, I think that, Liz, what you're saying is absolutely correct, because any of us at any time can get an illness. And so people were often saying, oh, well, you're going to be on dialysis stuff, maybe you shouldn't have a child because you have an illness. But people have an illness 2 days after they have a baby or whatever. So you never really know. So that can't be the reason not to proceed. It's just the knowledge ahead of time.
Yeah, and how it's framed.
And I find with
Patients will
that's-
guide us for sure, and patients will guide us, and it's very amazing that they'll either take the same number that you have your perceptions about how you would interpret it, and they'll either say that number is way too high, or oh, that's great. And
I
so
think
it's
we
quite
end up
interesting.
touching on this topic a lot more. Like I find I do a lot more education and conversation about their expected renal trajectory compared to patients who maybe don't necessarily want a pregnancy. Not intentionally, but just because this requires like so much conversation about what it would be with and without that in their life. And so I find like with some other patients, we don't really talk about like what is the expected time to this or that, and like different ways that transplant might be accelerated, etc. But for these patients, it really becomes a big part of the decision making. But like you said, sometimes it doesn't influence the decision as we might expect it to. So that's been my experience too.
Yeah, Sean, you've got your hand up. Almost the last question. Maybe it is the last question.
Yeah, thanks, guys. That was a great talk. My question actually is how we operationalize follow-up of babies over the course of their lifetime when you suspect but can't really prove a genetic component to disease. Like I'm thinking of examples such as a patient behaving like secondary FSGS, in whom you've done genetic testing but can't demonstrate anything, but suspect strongly there's an at-risk allele, or patients who have a family history of nephrotic syndrome and you haven't been able to show a genetic mutation. You can measure patients with C3G who come back genetic testing negative, where it's easier if there's a genetic component you can test for. But how do we operationalize follow-up of babies as they progress throughout adolescence, so you don't have someone who's at risk of developing primary glomerular disease that then is just diagnosed late in life because they aren't followed up? I mean, I just recommend yearly urine testing with dipstick through their family doctors, but that probably doesn't even get I have no way of operationalizing that, and don't even know if that's the best recommendation to make. What are your guys' thoughts on that?
It's definitely a great point, and especially for all the people you mentioned, and even for the the Alport's spectrum of patients as well. So we embedded in our preconception and our post-pregnancy counseling, we found so many young individuals early that have had disorders because we've picked them up. I think we need a systematic way of doing it though, and I think children's might be a good way to do it. I think maybe we should be working with our nephrology colleagues at BC Children's to see if there's something we could do to systematically book follow-up appointments instead of relying on family practice for some of these patients. It's a great point.
A little bit tough when they don't have a variant and they've seen medical genetics, because then we can't really follow up other family members for testing at the moment. But I think like educating the women themselves is one aspect of it, because at least it can be another touch point for follow-up later in life and ensuring that children are screened, like from a clinical point of view, just imaging, urinalysis, etc. But yeah, tying it all together for follow-up is a little challenging, I think.
Yeah, and I might suggest that even if it's not a genetic cause, I think there's still like a known genetic cause or variant. It's still, I think, worthwhile for mothers of children to appreciate that their children should have their blood pressures and their blood pressures done and urines dipped throughout their life, because that's worthwhile, right? So we educate a whole new generation of people around early diagnosis would be terrific. Well, we're exactly at time. I want to thank the four of you, including Kate, for starting us out in a good way with a story that reminds us why we do this, and to our excellent panelists for a really great and informative talk, or set of talks actually, and for all of your efforts and to ongoing work in this area and knowledge translation based on data that we generate here in BC. So thank you again very much. Okay. Bye, everybody.